Very interesting presentation, Vinny. So, just to start off a little bit off the subject, who are you putting in, or what age are you putting in mechanical valves now? Has it changed? Are you putting them in older patients, giving the durability issues, or what?
That's a great question. Means Molly, as you know, that my background was in London, United Kingdom, and interestingly, patients were always given a choice of what they want. And as I said, I started training there in 2000. The age cutoff was 70, and we used to tell patients below 70, we would advise you should have a mechanical valve. And when I say mechanical, essentially we are discussing aortic slightly separate, and it's mainly aortic what we're discussing. And slowly the trend changed. And when I became attending, my first patient was actually a 40-year-old. And he said, I don't want mechanical valve because I don't want to fall. I go skiing with my kids and I rather take reoperation. So we slowly saw that in UK, nearly 98% of patients getting AVR were tissue valves, irrespective of the age. And only the young patients probably were they're really young, I'm talking about less than 40, will probably be convinced to have a mechanical. In United States, I was pleasantly surprised in some ways that there's a conversation, and I think in my practice in Colombia and Sushil in the valve clinic, I think anybody we would say below 55 for sure should go for mechanical valve. I think slowly and surely the cutoff was coming down, and even patients less than 65 were reluctant to have a mechanical valve. I mean, if you look at from patient's point of view, as one of my residents asked me one day in London that, but if I'm alive after 10 years, I'll have a reoperation, that kind of thing. So I think, again, it's a very valid question because when we see survival curves, even aortic valve replacements at age of 50, at after one decade, everyone's not alive. That's what I mean. So I think it will be good to have better durable tissue. And as I mentioned before, the generation one pericardial valves were made because the aim was to have no anticoagulation. That was the main aim. The second generation tissue valves were made to make sure that the durability was a bit longer. And now, of course, the third one, we are thinking of not only the durability should be longer, but they should be TAVR friendly as well. So I think it's a evolution. The process is constantly evolving, and I think that's where we will lead to. Means polymer valves is something we talk about a lot, and I would like to hear your views as well, what you have heard at present. But I'm always a bit skeptical about it because I've seen many coming and going since I started training in heart surgery. So uh, I had only a brief opportunity to explain the challenges in polymer technology in my slides.
I think the best polymer valve out there is a mechanical one.
It's very true.
That's been really issue, isn't it, Ben? It's been like trying to make a mechanical polymer thinner to be more like a tissue valve, and it's a bit of the holy grail. And I would love to hear what your thoughts on. I know Foldax has done a number of implants, but it's something that I think we could easily try to aspire to. But it's been, as you say, a decades long search.
I think there is a starting point somewhere, and I think the starting point is always a surgical valve. And the reason I'm saying that is because you can implant it without touching the leaflets. Star Edwards device, which was the first mechanical valve, the first training was don't touch the metal or the ball with a forceps. So functioning element should be untouched. And the reason is if you cause any microscopic injury, it will generate thrombosis and problems. Now, I think some of the scaffolds, etc., have been used in TAVR designs and they have failed. And the reason is not only we are crimping them down, but we are also expanding them later. And I think we are already challenging the tissue, which we haven't proven yet, polymer, not tissue, but polymer. And I think reading a lot about what polymer technology is today, so to speak, it is now called a fusion technology because, the early polymers were pure polymers like polyurethane, Gore-Tex, but now it's a fusion technology and they have the same issue. Like, for example, the SIBs, which I mentioned earlier, and I showed the pictures, because of opening closing, there are fractures developed in the outer coating, and that exposes the dacron below, and that leads to calcification and etc. So I think we just need to slowly understand what promise it holds really.
Vinny, how much more life will these different tissues and give to these valves? What are we talking about? Are we saying the same as the life of a mechanical valve, or a couple of years, or do we even know?
So interestingly, you said that, but mechanical valves can, in theory, last for 100 years or more. They don't show degeneration in the hinges or etc. But the tissue valves, you are spot on. But personally, I challenge my own surgical understanding more than probably most people. Is I don't know the starting point. The starting point is we always get told that this valve will last 15 years, this valve will last 20. I I don't think that's a good starting point, because that's all, the survival curves are projected survival curves. Only few patients reach 15 years. So I think the comparative experiments in juvenile sheep or subcutaneous tissue of rabbits, etc., have shown early promise, because at say 6 months, the perimount tissue shows more calcification than the resilia tissue, or adapt tissue, which is the science by admitters, shows zero DNA, so less chance of calcification. And the patches which have been used, core metrics, have shown no calcification in pediatrics. So I think there is definitely promise. The main worry is when you stress it, that means you open close 1.5 billion times, can it last? And I think that's very hard to replicate except for time.
Vinny, great talking, great concepts. You had mentioned now in both of your lectures that there's extra stress when you crimp the valve and then when you post-dilate or expand it. How much time does a valve need to last so we could actually put this to rest, whether it really is a very if it's an important factor or not important factor in deterioration? And as the leaflets become thinner, how will that impact this ability to either crimp or expand?
So first of all, the leaflets are already thin. Means we know that, right? Means the leaflets of TAVR devices are thinner than surgical devices. So I think that we have reached the thinnest point, in my opinion. I don't think we are going to go thinner than that. Now, porcine leaflets are thinner than bovine, and bovine are thinner than equine. But equine tissue has got more integrity. That's because the way elastin and collagen is dispersed in the tissue. So I think the effect of crimping, and I showed that example to you just to show you the effect of normal ballooning. I'm not even talking of high pressure balloon. Uh, I know that there is some experimental data coming from industry supported studies that there is no damage at all. It's hard for me to believe it. But I wonder whether the damage is early so that it leads to more thrombosis rather than tissue degeneration. And maybe that particular case I showed you, it raises a question in my mind that actually maybe we should anticoagulate these patients for 3 months. It may not affect degeneration, but it may affect the early halt, etc., which we see in some patients. So it just raises a question, and I think we should continue to raise this question. Polymers, interestingly, have never been studied with high pressure balloons or even balloons. Most of the polymer devices, as you can see, are self-expanding devices. So the question is, when you post dilate them, what's going to happen? So that's another interesting area to study in future.
So
it's important. Oh, sorry, go ahead.
No, go ahead, Sushil.
No, I think the point that was made on a previous discussion that it's not just the tissue science that's going to impact durability. It's valve design, it's the patient sort of milieu, and a lot of other factors. So a lot of the stuff is important. But to Molly's point, I would just say, how many more years do we need? Small changes can make a big difference, because all we're talking about is management of a patient lifetime. So in a 70-year-old, if you go from 10 years to 13 years, then that may be the difference between getting away with just one valve and not being able to, or not being able to get away with that. So these small differences can make big patient clinical differences.
No, I completely agree, Sushil. I mean, I think that's what we are looking at when we speak of lifetime management. I'm still convinced it is 7-year increments. And if you look at some surgical valves which failed early, they were at that 6, 7 year point. They suddenly start going downhill. So I think the main challenge, you're right, and that's why my definition of young and old patient is very simple. We have to individualize it. We have to make sure that a 65-year-old, we understand the comorbidities and then match it to the current durability understanding we have to decide whether he is young or old. We can't have separation at 70 years, we're going to do this, and 60 years, we're going to do this. So I think till the durability data becomes clearer, I think we have to individualize our selection process. And time has come where we say bioprosthetic valve, it applies both to TAVR and surgical valve. They are not separate anymore. I
Okay,
think TAVR, yeah.
here's a question for you. So, absent a significant morbidity, and we'll go into the panel here as well. What is the youngest age you would do a TAVR in, you feel comfortable in, absent a morbidity?
So I think this is very interesting. I think this is the reason in my first presentation I said how we are going to learn about TAVR explants as well. And in fact, I would stretch it further. A young patient comes and says, Dr. Saraja, I'm the only earning member of the family and I want to go back to work. I don't want this 2 months delay. And if his anatomy is good, I'm not that emotionally and ethically challenged that we should do TAVR in him. Because if we get a good result in him for right reasons, and then maybe when he's 60, he's retired, there's less pressure, etc. on him, I can explant the valve. So TAVR and TAVR explants are really the critical pieces of this puzzle. And I think we will learn, we will be able to, shake our guidelines into how we manage these patients once we understand those two. Currently, I think it is pretty unclear in my mind as well. So I would implant a valve, as I said, in a 40-year-old, if he wants a tissue valve, sure.
You would
I
do a
don't have a
TAVR in
problem.
a 40-year-old.
Means we have done in the past, but we would tell him the pros and cons. And as I said, Paul, this is the point. Point has come where a surgical valve and TAVR valve should both be considered as bioprosthetic valves.
Yeah.
That's what I mean. And we have to optimize the results in both. We can't offer one because it's less invasive, and we can't offer one just because we think it has been used for so many years in the past. I think we have to challenge the science which is thrown at us in the last 2 decades.
So
I think it has to be this lifetime management issue, though, right? The 40-year-old, if they're not going to take a mechanical valve, and you sort of try and figure out, can I get them through, and they have a good valve for a large transcatheter valve, and can you get them through their life with one surgery, right? And
Yep.
If that discussion happens and the patient's engaged and it's an informed discussion, I have no problem with that. It's the question of patient understand limitations, we understand the process, and to Vinny's point, I mean, what I've always told the patients is we don't know what the durability is going to be. We don't know how hard it's going to be to explant, but we do know what your risk of a transcatheter valve is based on your CT. And your anatomy is ideal. It's not zero, but you're low risk, right? And you're low risk for surgery. But those type of questions, because that first surgery is low risk, but the second may not be as low risk. And I think those are the conversations we need to have with the patient.
Well, so to your point, Sushil, I think the lower risk patients and the younger lower risk patients have become a much harder population to deal with, and you have to put much more thought into it than the intermediate or high risk, because for the intermediate or high risk, you just throw in a TAVR, or they get nothing.
75 and above, and it's fine.
Yeah, I think
but
this
the low risk, you have to understand these concepts. You have to understand the anatomy. You have to understand how good your surgeon is too, and who they're and whether or not in the future that they can explant the valve if you do a TAVR. But I tend to agree with Vinny and Sushil. If they don't want a mechanical valve, then it's hard for me to say that there's a difference between a surgical tissue valve and a TAVR tissue valve.
I think one of the things I have a difficulty with, and I'm curious what other people on the panel think, a 70-year-old low-risk surgical candidate with a BSA of 2 that's going to get a 23-millimeter sapien.
Oh yeah. No.
What should that be? What is the conversation with that patient?
yeah,
It's going to last their lifetime.
So,
type of thing.
We're
Yeah,
losing
my
you.
question about the earlier age,
Go ahead.
my question was assuming that TAVR is technically completely doable. But that's a very hard question. And along those lines, I think we should move on to your talk, Sushil, because you're going to be talking about bicuspid disease, and we'll continue this conversation.